quietly and still get the food while Dr. Byers is talking, but please, again, do that quickly. It's my pleasure to introduce Dr. Tim Byers. Dr. Byers is the Associate Dean and Director for the Center for Public Health Practice at the Colorado School of Public Health. He's a physician and a professor of epidemiology, and he's my mentor. So I've had the pleasure of working with Dr. Byers since I was a graduate student, like you guys.
So you have me to blame.
No, I have you to get the credit too. So it's such a treat to have him today here. You hear a lot about HIV and malaria and all the infectious diseases, but as I mentioned before, with the dual burden of disease and people dying more of chronic diseases than of infectious diseases, it's time to really focus more on non-communicable diseases. So Dr. Byers is going to talk to us about the global cancer epidemic. And like I said, it's a treat to have him here, so please join me in welcoming Dr. Byers.
Nice to be here. So what's an epidemic? An epidemic is the occurrence of disease in a higher than expected amount. For diseases that have short latencies, like many of the infectious diseases, we see epidemics day to day or week to week or month to month. For chronic diseases, though, we have to step back and have a broader picture, either a broader picture geographically or a broader picture in terms of time scale. So here's a quiz. What was the biggest epidemic in the 20th century in the United States? That is, by biggest, I mean that epidemic that took the most lives.
With great influenza? Was that it?
So you all have some answers in your head. The right answer is coronary heart disease. If you look at deaths in the United States, coronary heart disease really peaked in the 50s and 60s and has come crashing down. The death rates now from coronary heart disease in this country are 1/3 of what they were in the 1960s. Why? Well, because we figured out what caused it, we figured out how to prevent it, we figured out how to treat it. So the global cancer epidemic is ongoing, and it hasn't yet played out. This year, I'll tell you what, I'm going to try to experiment. But when I was going through my slides just now, it occurred to me that there might be a little trick that we can use in teaching whereby you'll learn better. So I'm going to experiment with you. In the first half of my talk, I'm going to talk about the global situation with cancer. The second half, I talk about what's going on in the United States as an example of what's possible globally to accomplish. I'm just going to go through the first half of my talk without saying anything. I'm going to show you the slides, and I'm going to ask you to do the mental exercise of imagining what I'm going to say when you look at these slides. So I'm just going to silently go through the first half of my talk, and I'm going to back up, and then you're going to actually hear it. So think about this. And I know I'm going too fast, but that's the point. Okay, so that's my experiment. I'd be interested to hear from you later how that worked. Okay, so the global cancer epidemic. So this year there will be more deaths in the world from cancer than from these four conditions combined. So when we think of international health, we typically think of infectious diseases, right? For good reason, because infectious diseases used to be the leading causes of death in the developing world, but they are no longer. In fact, deaths worldwide, there's about 8 million deaths from cancer this year, about 7 million from ischemic heart disease, about 6 million from stroke, about 3 million from chronic obstructive pulmonary disease, almost all of which is caused by tobacco. Diarrhea, HIV, TB, malaria, very important diseases, very preventable diseases, very treatable diseases. Yet the sum of those is less than the cancer deaths this year. So I'm not here to say that cancer is more important than any other disease. I'm here just to point out the magnitude of the problem and, more importantly, the magnitude of the opportunity that we have, because cancer is epidemic now. It's going up globally. It's not going up here in the U.S. It's actually going down. And if we figure out the causes of the epidemic, we can figure out how to turn it around. And we're doing that here in the U.S. and in many European countries, but in most of the developing world, they're on a whole completely different part of this trajectory. If we divide the countries roughly into quartiles based on their income, the y-axis here is actually numbers of deaths. And you see in all of the countries, regardless of income level, that the non-communicable diseases, what do I mean by non-communicable? Cancer, heart disease, stroke, chronic lung disease. There are some infectious factors in there in cancer, we'll talk about some of them, but basically the non-communicable chronic diseases really dwarf both injuries and communicable diseases as a cause of death, even in low-income countries now. Now, this wasn't true a decade ago. Well, it just began to become true about a decade ago, but certainly a generation ago it was not true. So when our thinking about international aid, our thinking about global development, our thinking about population and public health internationally was formed, and our mental and operational approaches to improving health in developing countries was formed, this reality wasn't totally understood. But as this picture indicates, the World Health Organization, the UN now, is beginning to realize that non-communicable disease prevention is the #1 opportunity for global health improvement from here forward. Here are counts. So notice the scales are different in the U.S. and the world. Obviously, the world's a bigger place than the U.S. But the point isn't the counts, but these are deaths in the world and the U.S. And the point is that the distribution of deaths by cause of cancer, or by the organ site in which the cancer occurs, is really quite similar. Now, there are some differences. A higher proportion of the GI cancers, colorectum, stomach, liver, esophagus, worldwide compared to the U.S., and I'll comment on some of the reasons for that. But the main point here is that there's quite an amount of similarity worldwide and in the U.S. Cancer appears to be more similar than it is different around the world. And if we look now at incidence, I'll just add blue bars in here for incidence counts. By incidence, I mean numbers of new cases that are diagnosed, not numbers of people who die of the disease. There again, there's a lot of similarities, a few huge differences. Prostate cancer, for instance, is very high in incidence in the U.S. Compared to internationally and so forth. And I'll comment on some of the reasons for that. But the point here is, if we look at counts or rates, here is rates of occurrence of cancer mortality in the U.S. compared to now not worldwide, but compared to developing countries. We see quite a similar pattern. The cancers that are common here are also common even in developing countries. They have some excesses that we don't, especially in the GI cancer, cervical cancer, some of the cancers that we think are caused by, in fact, infectious agents. And I'll get our comment more on that. When we look at cancer incidence for the U.S. compared to developing countries, here there's some big differences, especially in breast and prostate cancer, where we have a norm now that we do screening. We do mass population screening for these conditions, knowing that one of the byproducts of screening is that we are identifying some people with cancer for whom that cancer would not have metastasized, spread, would not have caused disease. And so one of the harms that we do in screening as a necessary step towards the benefits, which is saving lives, one of the harms is this condition called overdiagnosis. It's a big problem in prostate. It's a problem as well in breast. There may be as many as 1 in every 5 breast cancers in the U.S. today that are diagnosed by mammography never would progress to cause disease in the patient. The problem is that we can't easily distinguish those cancers from the ones that are going to progress and kill patients. So there's a difference in the pattern of incidence, less of a difference in the pattern of mortality between our country and developing countries. So I'm going to just take some of the top cancers and just give a snapshot of what's going on. So lung cancer and tobacco smoking are almost synonymous. There are some lung cancers that happen in non-smokers. And even among smokers, we know statistically some of the cancers occurred for other reasons. We have a long list of other reasons, including radon exposure, including other types of occupational toxins and so forth. But the fact is that around 15% of lung cancer we really can't explain yet. The amazing thing to me is that we don't all get lung cancer all the time. When you think about it, all the stuff that is in the air, naturally occurring, as well as other contaminants in the air that we clear through our lungs, it's amazing to me that there's not more lung cancer than there is. But tobacco is the big story, and the new realization that we've developed just in the last generation, really, is that for people who get addicted to nicotine early in life, which is almost all smokers, get addicted in their teens or early 20s at the latest, if they stop by age 40, then this lung cancer risk is almost entirely reversible. The cardiovascular risk, the heart disease risk, and the stroke risk is reversible almost immediately upon cessation within the first week or so. And the lung cancer risk is largely reversible with cessation before age 40. And this is important because a lot of people who have been smoking for 10, 20 years feel like, well, it's too late to quit because whatever damage has been done has been done. And the evidence is that that's not the case. Here's this cigarette pack that we're looking at. I think it's from Australia, I'm not sure. The one down there that has a nasty, dirty mouth with bad teeth. Other countries are doing a better job in advertising restrictions than we are in the U.S. I took part in this activity, which was a large systematic literature review by the World Cancer Research Fund looking at nutritional factors in cancer around the globe. And the reason I wanted to highlight this was I think when I went into this, I thought that what we were going to end up with was very inadequate evidence, apart from developing countries, about the relationship between foods and obesity and physical activity levels, which sort of together means nutrition, and cancer risk. And I thought that because of the variation in different countries in cuisine and foods and types of cancer, that we would not be able to achieve a consensus on what nutritional factors are really impacting cancer risk, but I was wrong. At the end of this, we reviewed the literature from everywhere. We had representatives from each of the continents, except Antarctica, I guess, which isn't a real continent, I suppose, demographically. And we achieved a broad consensus about the importance of nutrition, especially 3 factors. obesity, physical sedentariness, and alcohol were the big nutritional factors. But when we sort of sum up the effect, the fraction of all cancers that we think could be due to nutritional factors, summing up obesity, physical activity, alcohol, fruit and vegetable intake, and a number of other smaller factors, we get fairly large proportions of esophageal cancer, stomach cancer, colorectal and breast cancer. I just pulled these as examples that are contributing substantial proportions of the cancer risk in different countries. So if we look here at the U.S., for instance, and I'll just highlight the 38%, my pointer show up here, yeah, the 38% number here. This would be the sum of the effects of obesity, physical sedentariness, and alcohol, which are the big three nutritional factors for breast cancer. Meaning almost 40% of breast cancer we can attribute to those combination of those factors. Well, look here across the countries. Now these vary, but they don't vary that much. Mostly China varies, not because those factors are impacting cancer differently, but because those factors are less common. In this case, women in China, less obesity, less physical sedentariness, less alcohol use. But the remarkable thing to me is, even in comparing developing to developed countries, we can still attribute a large proportion of cancer to nutritional factors. And I wanted to highlight that as we go into breast cancer. There's clearly higher risk in developed countries. This little heat map here of the red colors are high risk areas, and as we go towards green colors, that tends to be lower risk areas for breast cancer. But the trajectory of breast cancer is quite different. In developing nations now, breast cancer rates are increasing quite rapidly as women become more sedentary, women become more obese, women begin drinking more alcohol. And so the shape of the epidemics are different. Even though the risk is higher here, actually rates for breast cancer are coming down fairly precipitously in the U.S. and other developing countries, while they're going up in developing nations. So there are some countries in Africa, even though this is green, there are some countries in Africa where breast cancer is becoming a leading cause of death in women in midlife, the 50 to 64 year age range. So not inconsequential. And really the needs for breast cancer in Africa are different than here. It's not likely that we're going to be having mammography machines all across sub-Saharan Africa, but that's probably okay. Why? Well, because we now have treatments that are fairly cheap, anti-estrogen treatments that are fairly cheap, that can even cause advanced breast cancer to regress to the point where women can live for decades with fairly cheap anti-estrogen therapy. So it'd be nice to have mammograms in sub-Saharan Africa, but the norm there now is that a substantial number of women with breast cancer present when their breast begins to fall off, as it will, as the tumor will grow and eventually block off the blood vessels, and what's called an automastectomy happens. Now, so the challenge in many nations in Africa for breast cancer is what to us we consider old-fashioned breast awareness that we did in the 50s and 60s here. That saying the word breast, touching the breast, talking about the breast, having somebody else examine your breast if you have a problem there is not taboo here anymore, but it's taboo in Africa. So the approach to breast cancer in Africa is going to be just to demystify and deal with the cultural taboos of the breast, and a lot of progress and a lot of suffering can be prevented. Obesity, physical activity screening are clearly factors, and we need to do better worldwide on that. But in the absence of screening, there's still a lot more we can do. For colorectal cancer, the map looks very much like breast cancer in terms of where risk is high and where risk is low. The interesting thing about colorectal cancer is that if we track people who migrate from areas of low risk to areas of high risk, we find that their colorectal cancer risk changes almost immediately. Within the first generation after migration, immigrants to the U.S. from Asia have as high, or in some cases higher, risk of colorectal cancer when they become adults than they had in China or Japan or wherever they came from Asia. What does that tell us? That tells us that these big international variations are not genetic. Genetics changes over eons, not over a generation or two. It tells us there's something about the life experience, something about the environment, something about the diet, tobacco, physical activity, maybe other factors in the environment that are causing colorectal cancer. And for colorectal cancer, we have a long list of factors that are proven to be causal. Actually, tobacco is one of them. Physical sedentariness is a big one. Obesity, not enough vegetables, too much red meat, the way meats are prepared. All of these add up for colorectal cancer risk, and it makes a big difference. But despite the fact that there's a long list of nutritional factors, no matter how crummy your diet is, no matter how sedentary you are, no matter how much extra body fat you have, you can prevent colon cancer by finding and removing the precursor lesion, which are polyps or adenomas in the colon. And the only way to know if you have those is have somebody look up in there and see. So about 60% of Americans have now had a colonoscopy, and that's going up fairly rapidly. And as a result, colon cancer is really diving fairly quickly because you find and remove the adenomas. Cancer comes from the adenoma, it doesn't come from the normal colon. You can prevent colon cancer as a result. So can we do colonoscopies across Africa and Asia? Well, why not? It doesn't have to be that expensive in technology. Can we treat HIV in Africa? Yeah, even though it was thought to be too expensive and not affordable. We've got to think outside the box, I think, on if we really want to prevent cancer, how can we do it? We have at the medical school, we bought some simulators for colonoscopy, which are these computers in a box, and then there's a scope on the outside, and you poke it in there, and then there's a screen, and the computer simulates going through a colon. And if you push it too hard in the wrong direction, the computer goes, oh! You know, that's the kind of feedback as clinicians we want. And so you can actually score yourself. You know, you get all the way to the cecum and back, and did you see the polyps or not, and you saw them. With that kind of machine, you can train teenagers to do colonoscopies. Now, I wouldn't recommend it, but you could. And so the technologies are there to actually offer high-level care for low cost with the right kind of training and the right kind of policies. Esophageal cancer is different. Look at the pattern there around the world. Now we have higher risk in developing countries. Lots of question marks. The U.S. National Cancer Institute noticed that the risks of esophageal cancer in Linchan, China, not far from Beijing, were about 100 times what they are here in the U.S. And so they thought, well, there must be a gold mine there. We're going to go in and we're going to figure out what's causing this. And they went in about 20 years ago, and they still haven't explained it adequately. They found a number of factors, some genetic factors, some dietary factors, but essentially it's largely unexplained. So there are a lot of question marks. It looks like micronutrient deficiency plays a role, but micronutrient deficiency is widespread around developing countries, yet it doesn't fit the pattern of esophageal cancer risk very well. We know that hot beverages play a role, and there are some cultural practices of, it's not our Starbucks thing, it's like boiling water in shots down the throat. And that appears to also be a factor for esophageal cancer because it causes damage. Basically, anything that causes damage to bodily tissues on a chronic, repeated basis can cause cancer. If you take a chicken and you start picking at a spot on its wing, and you pick at that spot every day and it won't heal, eventually a cancer can form there. If you damage the liver with virus, to the point where the liver has to be constantly repairing itself because the cells are being killed and damaged, cancer can form there. If you have ulcerative colitis, a condition in the colon that causes the lining of the colon to be constantly damaged and inflamed and trying to repair itself constantly, cancer will form there at a very early age. So anything that can sort of inflame the esophagus can cause esophageal cancer. And we now know in developed countries, obesity is one of those things. High abdominal fat levels lead to high pressure in the abdomen, leads to reflux, leads to an influx of TV commercials for heartburn, which we've all seen, epidemic of heartburn, and obesity causes cancer only in the lower third of the esophagus where the heartburn damage happens. So esophageal cancer, a big deal in developing countries. We don't have all the answers, but it's a highly lethal cancer. Stomach cancer was the leading cause of cancer death in the United States 100 years ago. Now it's pretty rare. Much more common in developing countries where stomach cancer is the leading cause of cancer death in many places, especially in Asia. There's a bacterium that can live in the lining of the stomach called Helicobacter pylori. Kind of an interesting story. There was a physician in Australia who noticed that these bacteria were there on pathological slides of duodenal and stomach ulcers. And he hypothesized that Helicobacter pylori infection in the duodenum, which is the first part of the small intestine that comes off the stomach, he hypothesized that that actually caused ulcers. And he was ridiculed scientifically because, of course, it doesn't cause ulcers. We know what causes ulcers. It's spicy food and bad diets and all that. So in the 80s, he really pushed this idea, and he reasoned that if that were true, that if you treated ulcer patients with antibiotics to kill the bacteria, that would heal up their ulcers faster. Turned out it did. What the heck? And now we know that duodenal ulcers are largely caused by this chronic bacterial infection, not by eating spicy foods. Now the question is, since that same bacterium can live in the stomach, does it cause stomach cancer? And we have not proof yet, but we have pretty good circumstantial evidence that the answer for many stomach cancers is probably yes, that chronic infection with Helicobacter pylori probably causes stomach cancer. Why then did stomach cancer rates in the United States dive over the last century? We haven't figured out how to treat it any better. We don't have any vaccines for it. We don't have any other preventive things. The leading thinking now is that what's happened is with the general socioeconomic improvement in the U.S., we're not crowded, we don't live in tenements anymore, we don't have multiple families living together, we have generally available clean water, generally available good hygiene, that's led to a decline in this infection of Helicobacter pylori. If you look internationally, the infection in the stomach of this bacterium correlates well with poverty, with poor living conditions, poor sanitary conditions. So this is probably, even though cancer is called a non-communicable disease, this is a leading cause of cancer in the world that is probably caused by an infection. And that we think probably is therefore not only preventable by improving sanitary conditions generally, but also treatable. If you could identify people who have chronic infection, treat them with antibiotics. And there have been several demonstration projects on that. It works. The problem is that then there's a risk of recurrence. And so then the question is, are you chronically treating large populations with antibiotics? And as you know, there's adverse effects of that as well. So This needs to play out with more research, but there's lots of potential, I think, for preventing stomach cancer through improved sanitation and probably through strategically well-done antibiotic treatment programs as well. Prostate cancer, and I forget what these two are. I think one is death rates. Yeah, so on the right down here are death rates, and these are incidence rates. And so there's wildly different incidence because of PSA testing. Prostate-specific antigen is a protein. You can detect it in the blood. It comes from cells in the prostate. So if there's something bad going on in the prostate, it'll spit out this protein. And if that's an infection, or whether it's cancer or whatever, you can get high rates of PSA in the blood. And then that's a trigger for then doing a further test, a biopsy, to find out if there's cancer present. Unfortunately, with prostate cancer, most men have it. I probably have prostate cancer right now. I'm 65, and the statistical likelihood from autopsy studies is if you look very carefully in my prostate, you'll probably find a cancer there somewhere. So then the question with PSA testing is, are we finding cancers that are going to kill men, or are we finding cancers that are not going to ever cause any symptoms in men? And the answer to that is yes. We're doing both, and we know we're doing both. But there's a lot of difference, therefore, between incidence in countries that do PSA screening and incidence in countries that don't. But look at the mortality differences. The mortality differences are not in the same pattern. The risk of dying from prostate cancer in some African countries is about the same as it is from dying from prostate cancer among African American men. So the disease isn't varying as much as the way that we detect it. And so prostate cancer is a huge problem, even in developing countries, especially in black men, including those in Africa. There's a lot more we need to learn, but just like breast cancer, we're learning that through treatment, we can control the disease, not just for months or years, but maybe for decades, and turn even a metastatic case into a chronic disease that can be managed. Liver cancer is caused by anything that chronically picks at the liver. Viruses are an important thing. Alcohol is another thing. So the risk factors for liver cancer are chronic alcohol abuse or chronic infection with one of the hepatitis viruses. We now know from vaccine trials for hepatitis B that vaccinating against chronic hepatitis B infection early in life not only prevents chronic hepatitis B infection, but actually prevents liver cancer. We know that from Taiwan, where they started the vaccination trials long enough ago that the kids who were in those trials are now in their 20s and 30s, and we can see that the liver cancer incidence is quite different depending on whether they got the vaccine or not in those trials. So the challenge for liver cancer, I think, is chronic hepatitis virus infection prevention, which means vaccination, which means making sure that the hepatitis vaccines get into the regimen of vaccines for childhood and beyond internationally. Cervical cancer is another cancer caused by a virus. It's a different virus. It's the human papillomavirus. Variants of the same ones that cause warts on our fingers. Different subtypes will cause chronic infection in the urogenital tract. And so it's a sexually transmitted disease. It can be carried by both males and females. In males, it does not create a cancer in the urethra where it can be chronically shed. But in males, it can cause oral cancer. And if you wonder how a sexually transmitted disease can end up in the oral cavity, I'll talk to you after cervical cancer was a leading cause of cancer death in the U.S. Among women. The leading cause in women 100 years ago. Now it's very rare, and basically it's because of Pap smears. Well, what do Pap smears do? They don't detect the virus. They detect the early change that happens as a result of the chronic viral infection, some dysplasias, some changes in the cells. That happens years or decades before that chronic infection will lead to cervical cancer. So that by Pap smears, we find that, we treat the cervix and prevent the cancer. But vaccine is going to even be better. Vaccine will prevent the infection itself, and hence prevent the dysplasia that leads to cancer and so forth. Unfortunately, right now we have a vaccine that only covers 70% of the serotypes or the subtypes of the virus that cause chronic cervix infection, but it won't always be that way. That's going to go up. New vaccines are going to get cheaper. New vaccines are going to get better. They'll cover more cervical subtypes. So vaccinating against HPV is going to prevent a lot of cervical cancer, but it's also going to prevent a lot of oral cancer. We have a bit of an epidemic of HPV-caused oral cancer in this country, just as the tobacco-caused oral cancer is going down. So the rates of oral cancer are about steady. You would have predicted they should be coming down because of what we're doing with tobacco, but they're steady because the HPV types for oral cancer are actually going up. So quick comment about the status of cancer in the U.S., and then I'll take some questions and facilitate some discussion. I'm going to do this quickly because the reason for talking about the U.S. now is going back to developing countries. What are lessons that we're learning here in the U.S. about cancer that we can apply globally? So 100 years ago, this was the situation. It was mysterious, largely fatal. We thought it was a single disease, and we didn't talk about it much. Now, we're starting to understand the actual biology of it. Even metastatic cancer is becoming curable in some cases, or certainly controllable as a chronic disease with medications that are tolerated very well. And importantly, we see cancer as a set of diseases, not a single malady. There's probably 20 different kinds of breast cancer. We call it breast cancer. Well, these seem to be about 20 different diseases, and they're treated all differently now, and we're beginning to understand it. Back in the early 1990s, the American Cancer Society challenged this country to reduce cancer mortality by 50% by the year 2015. So let's track how we're doing with that. Let's start with breast cancer first. I'm going to show you some plots. I'm going to show you y-axes that are the percent of the 1990 rate. So, for instance, if the 1990 rate as a percent of the 1990 rate is obviously 100%. And then I'm going to say, well, what's going to happen over time if we go to 100% to 50%, which is the American Cancer Society challenge goal. So what they said was over a 25-year period, let's try to cut the death rates in half. Well, what's happened with breast cancer is this. These are the U.S. death rates for breast cancer. Pretty much on track to be a success story. And then here's what's happening in Colorado. A little more noisy because of the smaller numbers. But basically, in a generation, we're going to cut the risk of dying from breast cancer in half in this country. Half of that is due to earlier detection, and half of that is due to improved treatment. None of it's due to prevention from obesity, because that's actually gotten worse, or to eliminating alcohol intake. Colorectal cancer, here's what's happening nationally. It's very much like breast. It is a different curve, trust me. But it's the same thing. Colorectal cancer is going down, largely because we're finding and removing adenomas. And in fact, I think the trends in adenoma removal are such that by the time we get to 2015, I think we're going to have less than a 50% of the death rate from a generation ago. Prostate cancer actually is the same thing, which is interesting because we know that PSA screening really doesn't have that big of an impact on mortality, interestingly enough. But we've made great progress in treating and managing prostate cancer as a chronic disease. Remember, these are deaths or death rates. So there's a lot more men with prostate cancer, a lot more men on anti-androgen treatments, and they're being maintained with a high quality of life for a longer period of time now. And Springs, Colorado. Lung cancer is a different story for men and women. Virginia Slims, you know, the whole messaging to women that they can be like men with regard to tobacco intake. The whole Virginia Slims thing kicked in so that when you look at the shape of the tobacco epidemic in men and women in the U.S., it's different. More than half of men in the 1950s smoked, and it was not that common in women back then. And so men quit it, and then women took off in the 70s and 80s and 90s, and now they're coming down as well. So the rates are coming down for women, but there's no way women are going to get to half of where they were. They'll probably just be down to 10 or 20% less, but for men probably so. And this is all due to tobacco control. Our improvement, we have had improvements in how we treat lung cancer, but those have been fairly recent, fairly small. This is all tobacco control. If we look in the U.S. and look at the effect of policy on tobacco control, we see here in the U.S. beginning in about 1990, and I'm just going to highlight men here, death rates did start coming down, as I just showed you, but it varies in different states. Here's what happened in California. Death rates started coming down in the 1980s in California because they were more aggressive with tobacco control and have really been a national leader in tobacco control. And by contrast, here's what's happening in Kentucky. Now, I love Kentucky, but I do want to pick on them when it comes to tobacco control. Right now, the risk of dying, if you're a man, the risk of dying from lung cancer in California is what is that, 45, and in Kentucky it's 90. So about twice. So my view on this is, why should we have children growing up with different exposures and different social norms about tobacco in Kentucky compared to California, just because we have a political policy decision that tobacco control is a states' rights issue, not a federal issue. More people die from lung cancer than breast, colon, prostate combined in the U.S. It needs to be federalized. Our tobacco control needs to be federalized. That's my only political statement that I need to make. So what have we done in the last 100 years? We've done these things in the U.S. And we've begun, therefore, to imagine a victory over cancer. Where for the 4 leading causes of cancer, lung, breast, colorectal, prostate, we're achieving something like cutting in half the deaths just within a generation, and we know why. War on tobacco, earlier detection, improved treatment, trying to make sure there's access to what we know more broadly. The Affordable Care Act is another step in that, trying to make sure that the social class disparity that we see in cancer outcomes can get eliminated through that policy change. So these are the cancer deaths in the world in thousands in 2008. 7.5 million. I talked about 8 million. I think that's because there's some other cancers that aren't here. Here's my estimates of preventability. We can prevent 70% of these lung cancers, 50% of the breast cancers, and so forth. And when you sum these up, now can I snap my fingers and make that happen? No. But I can imagine, I can do the thought experiment whereby the factors that we know that are causing these cancers and where we've demonstrated that here in the U.S. we can intercede, I can do the thought experiment that says globally that could be done. So how much of this 70% risk reduction from lung cancer do I think is actually achievable? Doesn't matter what I think. It matters what you do. That's the reality. How much of this breast cancer is achievable? Liver cancer and so forth. We know what factors cause cancer. We know what factors cause cancer deaths. There's more research to be done, of course. But the glass is more than half full. And the question is, how can we implement prevention? There are organizational roles for that. The UN has made a declaration on non-communicable diseases. There are cancer particular National Cancer Institute, International Agency for Research on Cancer, that are doing work on research and surveillance around the world, and lots of non-governmental advocacy groups who are beginning to be more active in cancer. The UN General Assembly in 2011 made a political declaration. I won't leave it up here long enough for you to read it all, but basically it said we're going to get serious about non-communicable diseases. It's time that we put them in their proper place. This is a threat to development, an economic threat, and there's a moral imperative to do more to prevent non-communicable diseases, heart disease, cancer, chronic lung disease worldwide. And then finally, there's individual roles as well. We can all, of course, drop everything and move to a developing country, and some of us will do that. Some of you will do that. But even if we don't do that, we can work organizationally within our organizations to continue to move forward progress on tobacco control, nutritional improvement, access to treatments for diseases, and really we can globalize our approach to service, I think, much better than we do. Lots of opportunities. Tobacco, nutrition, persistent infections, it can be dealt with in various ways, early detection, changing taboos, treatment, and then the final highlight I'll mention is palliative care, because despite our best efforts in prevention and our best efforts in treatment, there are many end-of-life quality issues, and many people living, especially in developing countries that have policies against narcotics, living at the end of their life in excruciating pain. One of the first initiatives that the American Cancer Society has taken in its global work, well, two, side by side, tobacco control, but also pain management. Trying to work with countries who have actually laws against importation of morphine to change those laws to help in palliative care. So that's my comments about the global cancer epidemic. Yes, it's an epidemic in the sense that rates are going up around the world. Cancer is the leading cause of death in the world. But we shouldn't feel fatalistic about it. We know a lot about what causes cancer, and we know not just in the abstract, but from our own experience here in the U.S., that cancer can be turned around. And so there's no reason we can't do that internationally. Now, you don't go out and do it with white coats only. There's lots of political will that needs to be fostered and developed. There are a lot of adversaries out there, big tobacco being one, that needs to be properly dealt with in the proper way in different nations. But there's lots of low-hanging fruit in preventing death and suffering from cancer globally. Luckily, the other leading causes of death, heart disease and stroke, have similar risk factors. So there's no disagreement about tobacco, no disagreement about obesity, about nutrition, about access to effective treatment. So I think there's a new partnership developing through WHO and UN that hopefully some of you can get engaged in doing what we can to prevent non-communicable diseases around the world. With that, I'll take a few questions. Yeah.
What policy skill sets do you believe are important, I won't even say essential, in order to do policy work in the chronic disease area?
Let me ask you what your answer to that would be, because my sense from your question is that maybe you have some experience with policy or some interest in it. What do you think that the skill sets would be? Because there's all these policy issues. There's healthcare access, there's tobacco, there's nutrition policy. What would you say?
I would say first, one would have to have explored oneself and identified passion. I would say second, that one would have to have excellent communication skills. I think third, At the bottom of the list, of course, knowledge, but I think knowledge is the easiest to acquire.
Yeah, let me just respond to that by saying I think there's two kinds of credibility. One is your professional credibility. Are you really being intellectually honest about what you're saying? And then there's sort of the personal integrity credibility, which speaks to passion. And we've all seen people who are like too passionate and not credible professionally, but you have to be equally credible, I think, to impact policy in both of those areas.
The other thing I was going to mention is a non-judgmental approach in order to get the conciliatory from the various turf interests between commercial and professional, which leaves the patient and society in between.
Yeah, there's the personal, professional, then there's sort of the political economy issues that we can't be naive about. And then, of course, there's the preaching issue, especially coming from the U.S. You have to figure out a way around the barriers that should be there because of that disadvantage. Other comments or questions? Yeah.
This is just a specific question I'm curious about. So you were saying that a lot of men have like prostate cancer, but
Yeah.
a lot of them aren't, like, you don't die.
Won't
from it?
grow.
Did you say
Yeah.
that?
And so a lot we know from autopsy studies of men who die from bus crashes or heart attacks or whatever at different ages, that prostate cancer, very small prostate cancers within the prostate are very common at older ages. I think at age 65, my probability of prostate cancer is something like 55% or something like that.
So it doesn't necessarily.
And so it doesn't necessarily affect me. And so if my little prostate cancer stays in my prostate, I'm happy. Now, if that little prostate cancer decides to spread to the lymph nodes and then to my bones and then to my brain and my liver, I'm less happy. And so the problem we have right now is not being able to easily distinguish one type from the other. So a lot of work in prostate cancer is at the genetic level, trying to figure out what are the signatures of prostate cancers that are likely to actually cause disease versus those that aren't.
I have a couple questions. One, do you see a role for ultrasound to replace colonoscopy anytime in the near future?
No.
No. Two is, if HPV vaccine is running about $5 a dose right now, and that's cost prohibitive, what would the price level be where it would be viable as a mass vaccination?
Yeah, on that second question, I'll just say I don't know, because I'm not very good at health economics and so forth, but you put your finger on a very critical issue, and that is price, and the price point for preventive interventions. And that's going to be a big challenge moving forward, well, with all vaccines, but HPV is a particularly big one right now. And as for alternative technologies to find colon cancer, there's a lot of them. You can even send your feces to a lab and they'll look at DNA in there and try to find DNA that's been of the type that might have been sloughed off by a tumor versus of the type that's just sloughed off by normal colon, and that works fairly well. But all of the methods, including CT colonography, are also called virtual colonography, where you take X-rays of the abdomen and then a computer sort of re-simulates what the inside of the colon probably looks like. That works pretty well as well. I think the best technology is the one that can find and remove adenomas. All of these screening tests, you end up with a colonoscopy if you have an abnormality. So my view is let's just start with the colonoscopy and be done with it. Yeah.
I've read some research papers about tobacco control in China, South Korea, and Thailand. And in all three of those cases, there's a strong correlation between the increasing price of cigarette pack and decreasing prevalence of smoking. What's kind of ignored or overlooked too much is that as the price of cigarettes increases, so does the prevalence of other kinds of tobacco use besides smoking. So my question is, how desirable is it? How desirable is it to have people move from smoking cigarettes to less harmful forms of tobacco?
Oh, I think it's great. No, so other forms like snuff and oral causes oral cancer, but that's much less common and much less lethal than lung cancer, and you don't get the adverse heart effects as much. So switching is fine with me. I much prefer quitting, but switching is fine. One of the problems in some countries, including China, which is the biggest problem at the moment, is that the government owns the tobacco. The Red Army in particular owns the tobacco industry. And so the governmental motivations aren't clear about tobacco. And what we're seeing, I think what we're going to see in China is we're in a honeymoon period now because the adverse effects of tobacco on cancer and heart disease haven't fully blossomed yet, but they clearly are going up and they are blossoming. And China's going to have to make some decisions about what it wants to do about that. And so far they haven't made the right decisions, I don't think, on tobacco control. But here in the U.S., we're not doing great either. I mean, we've gone halfway there. 17% of adults in Colorado still smoke. There's no reason that shouldn't be 10%.
Well, one problem in China is that the majority of doctors are actually smoking.
Yeah, doctors are part of the problem. Yeah. It used to be true here too. Yeah, there's a hand up over here, and then I'll be happy to cut it off whenever you need to. Yeah.
Excuse you talked about a lot about the environmental and lifestyle choices that lead to cancer. I kind of wondered about especially for breast cancer and ovarian cancer, there's like the genetic marker they can find if a lot of times your mother died or grandmother died young. Is that found mostly in people of European descent? Is it a kind of globally thing that can be found, or? Yeah,
it's the genetics, the highly heritable forms of cancer do vary in different populations. The particular one you're referring to with the BRCA gene, breast cancer genes 1 and 2, it's actually a set of them. Kind of misnamed because they're more important causes of ovarian cancer, as you alluded to, rather than breast, and ovarian's more lethal than breast cancer. About 5% of breast cancer is caused by these strong family histories, which means multiple female relatives having either breast or ovarian on one side of your family, and those are occurring early in life. And so we can test for those genes now, and then the reason to test then is to do something preventive thereafter. And the most important preventive action for women who carry this gene is to have their ovaries out as soon as they're done having babies, so that the ovarian cancer risk comes down. Additional interventions can include prophylactic mastectomy, like Angelina Jolie did, but there's things short of that can be done as well. There are the breast cancer genes appear to be largely of European origin. You can actually trace them from the Spanish conquistadors in Central America and up through New Mexico. So they're in the Hispanic population as well. But there are some other familial genes in other populations as well. I'll have to say the familial genetics haven't been as well studied in the like Arab and African nations. There's probably more to learn. But I think our lessons are there that those are important in families that are loaded with cancer, but it's just a small proportion of the total cancer problem is caused by those. Yeah.
This is the just say no kind of question. Can you give us an idea of your opinion about behavior modification as the gospel, as opposed to policy decisions?
Yeah.
And
I don't. Yeah. So I to answer your question specifically, I don't believe in behavior modification as the gospel, but I believe in behavior modification. Why? Well, because people do change behavior. People do stop smoking. People do lose weight. People do get more physically active. People do get colonoscopies. You know, things that are not natural and easy, people do. So I think individual choice and behavior is part of it. But then I think our challenge as a society is to make the healthy choice be the easy choice. And so I didn't look at the food you all ate, but let's just say hypothetically there were choices of bad food and good food. You all would have eaten it either way, right? And so why not eat the good food? So the policy could be to have the good food. I don't know. I shouldn't have said that maybe. But that's the kind of thing where policy matters. Yeah.
So thinking on a global scale and maybe in more of the highly impoverished countries where just
general healthcare access is a problem. Do you think that the organizations like the World Health Organization, are they moving more towards preventive policies in these countries versus, you know, prescriptive or anything like that? Is there a shift there? Or
Yeah,
is it
I think there's
more?
I think what's happening is WHO and the UN are saying, gosh, what's the most cost-effective thing that can be done? And that's why they're going towards really the low-hanging fruit of things like tobacco control policies. And if you know, if we could make a huge dent in tobacco, that'd be huge.
Similar to that question, it's popular in global health these days to talk about using a vinegar solution to detect cervical cancer. Do you think, I don't know much
Yeah.
about...
Yeah, I can tell you about that. So basically, when you put acetic acid or vinegar on any mucosal surface, it'll nothing will happen unless there's an abnormality there. So if there's dysplasia on the cervix and there's an abnormality, the same kind of abnormality that you can detect with a pap smear when you look at those cells under a microscope, those areas will turn white. And so what that tells you is not that there's cancer there, but there's something abnormal there. It's probably a dysplastic growth, and then that can be treated locally, either by surgical excision, which is probably not preferred, or by cryotherapy, which is you freeze it, just like you freeze a wart, and it'll fall off. So that's very cheap, very easy to do, doesn't require microscopes. You can train people to do it, and it works quite well.
Any other questions or comments?
One more, could you comment on what we know about marijuana and lung cancer?
Yeah. But by the way, this is very nice food.
Well, falafels are out, I think. Didn't we have falafels?
We did have
She
falafels.
brought me the food, so let me say that your policy here works. So that's good. Yeah, so I would have presumed that any kind of smoke that you put into your lung is carcinogenic. And in fact, marijuana smoke does appear to be carcinogenic. But what's been surprising to me is that there's been quite a lot of studies on this. And the risk of getting lung cancer from smoking marijuana appears to be substantially lower than the risk of getting lung cancer from smoking that other smoke, tobacco. So tobacco is a more dangerous product in that it causes addiction and you end up with a higher dose, but also puff per puff it appears to be more dangerous. So I think with the levels of smoking that we're going to see increasing here in Colorado, I presume it's going to increase as a result of our marijuana policies. I don't think we're going to have an appreciable lung cancer epidemic as a result of that. On March 7th, the School of Public Health is going to sponsor a symposium in downtown Denver on marijuana and public health. And we're bringing in some national experts as well as local experts. And we're going to review what do we know about marijuana and heart disease, cancer, mental health, brain development, accident rates in car crashes and so forth. And so if those of you interested in marijuana and health,
Just let me know and I can give you directions.
let Madiha know and she can send you the link. It's a free thing. You do have to register. It's an all-day symposium on Friday, March 7th.
Okay,
Thank you all.
thanks very
I enjoyed
much.
it.